Well, welcome everybody to our first webinar for MHA's 2026 Consumer Series. Thank you so much for joining us tonight. My name is Kay and I'm a member of the team here at MHA. On behalf of Musculoskeletal Health Australia, we would like to take this opportunity to acknowledge the traditional owners of all the lands from which we're joining the webinar this evening and pay respect to the traditional owners and custodians of these lands and their continuing relationship to the land and waterways. So before we get started, just some housekeeping. We will have the chat open during the webinar, which is being monitored. So please, if you have any questions or comments, put them in the chat and we'll do our best to get through them all during the Q&A part of the session. Also, if after the webinar you still have some questions or you'd like some information or support, please call the Musculoskeletal Health Australia back pain, arthritis and musculoskeletal conditions, or as we like to call it, BAM helpline on 1800 263 265, which is a free service where you can speak with one of our highly qualified health professionals. So tonight's topic is all about stem cells and arthritis. And I think we can all appreciate that this is certainly an area of research that is of great interest, whether you're coming at it from a consumer, patient, or health professional perspective. And there are a lot of claims and differing opinions around its potential for treatment. So we're excited to hear from our very well qualified presenters to update us on the latest in this space. Our first presenter is Associate Professor Shireen Lamande, who is a Principal Research Fellow and Lead of Bone and Cartilage at the Murdoch Children's Research Institute and a University of Melbourne Principal Fellow. She has more than 30 years' experience and her work focuses on understanding the complexities of how bone, cartilage and joint tissues form and function, and using advanced modelling to uncover molecular causes of skeletal disorders and improving the quality of life for children living with these debilitating conditions. We also have with us tonight Professor Munsie, who is an internationally recognised leader in the stem cell research community. She heads a research program at the Uni of Melbourne that examines the ethical, legal and social questions raised by stem cell research, and is also a group leader in stem cell ethics and policy at the Murdoch Children's Research Institute. So we're very grateful to you both for making the time to join us and share your expertise. So on that note, welcome, thank you, and over to you.
Thank you very much for the introduction. What am I doing? I need to share my screen. Here we are. Sure. I hope you can all see that really well. So it's as you can see from my qualifications up there, I have I'm a scientist, so I'm not medically trained. I'm a scientist who's always worked in really basic research. So that's my background. And so tonight, I guess what I'm going to tell you about is I'm not reviewing the field of using stem cells to repair arthritis, but I'm just going to tell you a little bit about my journey and how I got to a point where, you know, we're really hoping that we'll be able to address some of the tissue repair, I guess, challenges associated with arthritis and other skeletal problems. So just we've mentioned the Murdoch Children's Research Institute several times already. And I just thought I'd tell you a little bit about the Institute, just so you can maybe put our work in context and the environment that I'm working in, and Megan as well. So the Murdoch Children's Research Institute is located at the Royal Children's Hospital in Melbourne. So it's an ideal environment to promote interactions between clinicians, basic scientists, ethics people, everybody involved in healthcare. It's a fabulous place to work, and you can see a picture there of the inside of the Children's Hospital, and MCRI is up on the 5th floor. So the director of the institute is Professor Catherine North, and she has a background as a clinical muscle disorders. And the institute, like, it's big, there are more than 2,000 staff. It's a very big institute, but the institute's research is kind of divided up into, I think, 6 themes, what we call research themes, and I've listed them here. They're clinical sciences, genomic medicine, infection immunity and global health, population health, and stem cell medicine. And both Megan and I are involved in the stem cell medicine theme. And I think it's probably accurate to say that MCRI probably has the largest number of people working in the stem cell area and using stem cells to model all kinds of diseases that affect every tissue that you can think of, and also using those models to search for therapies and take those therapies through to the clinic. I mean, when I say the largest, I mean in Australia. So how did I get to this point where I'm thinking about arthritis and tissue repair? Well, I've actually spent my whole career working on musculoskeletal disorders, and really up until fairly recently, it's been on inherited musculoskeletal disorders or genetic disorders. And I found this slide on the internet just a little while ago, and I thought it was a nice illustration because it kind of showed all the different areas that I've worked in during my career. And when I first started, I was working on not osteoporosis, but it was a bone disease with some similar characteristics. It was a genetic disease called osteogenesis imperfecta, or probably better known as brittle bone disease. And at the time I was doing that, we had no idea. We didn't really know what the underlying cause of this disorder was. And my research really showed that it was due to mutations in the main structural protein in bone, and that's type 1 collagen. And then after that, I worked for quite a few years, probably 20 years or so, on a form of muscular dystrophy, and again, a genetic disorder. And again, the form that I worked on was caused by mutations in an extracellular matrix protein. So again, a structural kind of protein, and it was a collagen as well, so collagen type 6. And then probably for the last 10 or 15 years, I've really focused much more on skeletal disorders, so on genetic skeletal disorders. So these are genetic disorders that affect the way that the skeleton grows. So they would be mutations in, I might have it on my next slide, genetic skeletal disorders. So there's a huge number of separate genetic disorders. And let me just stop what I'm talking about now, just to say, it can be a really complex area. I'm aware that some of the concepts that I'm going to talk about are really quite complex. I'm going to try and explain them as well as I can in an accessible way, but it's really hard for me in a presentation where I can't see you, I can't see any of you, and I can't see your faces. So I don't know whether I'm pitching it at the right level for the audience or whether I'm being a bit too technical. So please forgive me, but I will try very hard to pitch it at a really accessible level. So in terms of the genetic skeletal disorders, there's a large number of them, and they really affect the way that the skeleton grows. And some of them are relatively mild, so they might be, an early arthritis phenotype through to really severe malformations and really short stature. And some of them are so severe that they're lethal very early on. And the mutations can be in a whole range of different molecules that are involved in cartilage and bone development, or in sort of maintaining the cartilage and bone tissue itself. But the ones that I have always been interested in, and you probably got that already from the previous slide, are these structural proteins. So these are what we call extracellular matrix proteins, and they're the proteins that give tissues their unique properties and prevent us from just being a blob. And so the proteins that we've been studying the most are collagens, and collagen type 1, which is the main structural protein in bone, collagen type 2, which is the main structural protein in cartilage, and collagen type 10, which is expressed by a very specific kind of cartilage molecules. And so, and underneath, is just really a picture of the way that the bones form, that most of your bones form during early development. And I'll talk a little bit more about that in a minute. So how do we study genetic skeletal disorders? It's always been really quite challenging because the cells are not accessible. So we can't get cartilage and bone cells from people very easily. And, the ethics around doing that are also quite complicated. And so we've, for a long time, used cells in culture that are not the right kind of cells, and so they're useful models, but they're not perfect. They're not great. And even if we could get the patient cells, the chondrocytes, and they're the cartilage cells and the osteoblasts, which are the bone cells, when we put those cells into normal culture, where we grow them on the plastic in a two-dimensional culture, they don't stay like chondrocytes and osteoblasts. They change into just a generic kind of cell type that's not, again, a good model for the disorders. So, we've learned a lot from some of the sort of fairly primitive cell culture models. But we then moved on to mouse models. So we would make, the genetic changes in the mice so that would model the disorder. Now, that's, again, a useful model, but it's not great. And it's particularly not great for skeletal disorders because mice have very different biomechanics. And so often with a disorder that can be quite severe in a human, the mice look absolutely fine. And so again, they're really difficult to model the human skeletal disorders in. And so after sort of trying to work with these models for a really long time, and, we've made a lot of progress, but, there are severe limitations with these models. We thought to ourselves, what if we could model human skeletal development and genetic skeletal diseases in vitro, so in the lab, and use this system to identify disease mechanisms, so how do mutations cause disease, and to test therapies. Can we use this system to test drugs? And the obvious way to go was to use stem cells. Now, when I talk about in the rest of my presentation, the kind of stem cells that I'm talking about are what we call induced pluripotent stem cells. And the way that we get induced pluripotent stem cells is that we would get cells from an adult, or already differentiated, committed cell type. And so we could get fibroblast cells. So these are the cells that are in skin, and we can isolate them from a skin biopsy. But more routinely now, we would use blood cells. So all we would need to make these iPSCs is a few mils of your blood. And then in the lab, we can put them in culture, and then we can add some what we call reprogramming factors. We can add them to the cells, and then that changes them from their adult cell type back into stem cells. So it reprograms them. And then we end up with what we call iPSCs. And of course, what the stem cells can do is that they can divide, and we can get more and more of them almost infinitely. And then once we work out how, we can in theory make every different kind of cell type in the body. So if we want to model blood disorders or make blood cells, we can do that. We can make pancreas cells. So these are insulin producing cells. We can make all kinds of different nerve cells. We can make fat cells. We can make cardiomyocytes, which are the cells of the cardiac, of your heart muscle. Theoretically, you can make whatever cell type you like. And of course, people are making all kinds of different cell types. But in order to model the diseases, the kind of cell type we'd need to make is a chondrocyte. And to model and to actually use them to model diseases and to work out what's happening during development, this is the process that we would have to model in the lab. Now, this is a really complicated model, and I won't go through it all. It's not important to understand it all, but there's a few things that will help you understand some of the later data that I'm going to show you. So the first thing that's important to know is that in the embryo, or in the embryo during very early development, your bones, when your bones are developing, they form from a cartilage template. So what happens in your limbs is that you'll get chondrocytes, or cartilage cells will form, and that's the template for bone formation. And then with different growth factor signals and things, the chondrocytes sort of gradually mature and they become larger. You get blood vessels invading into the tissue, into the cartilage, and then eventually the chondrocytes, the cartilage cells, mature, and then some of them can transition to then become osteoblasts, or bone cells, and that cartilage is then replaced by bone. And this is kind of the process that it continues until you stop growing in adolescence. And so when you have a fully formed bone, so this would still be a developing bone, you have what we call articular cartilage, and this covers the ends of the long bones and protects it. You have this cartilage in the middle, where the cartilage cells are maturing, becoming hypertrophic, and then being replaced with bone. And eventually, when you get to adolescence, that growth plate closes over and you don't grow anymore. So this is the process that we would be having to model inside the cell in the lab. Now, when we talk about cartilage, you guys are probably quite expert at cartilage, but just to help you again for context with some of the other slides, the thing that defines cartilage is really the extracellular matrix that is made by the cells. And so every kind of cartilage contains these two molecules, collagen 2 and aggrecan. So collagen 2 is the main structural protein in cartilage, and it makes the cartilage strong. And this other protein is called aggrecan, and aggrecan draws water into the tissue, and it allows the cartilage to resist compressive load. So it acts like a shock absorber. And of course, you have the chondrocytes, the cells in there. So those three things are together what defines cartilage. And of course, when you have arthritis, you start to break down, particularly this proteoglycan, aggrecan, so that you lose that compression, the ability to resist compression. Now, this is how cartilage is defined, but in our body, there's lots of different kinds of cartilage. So, for example, we have articular cartilage that sort of covers the ends of the long bones, as I mentioned before, but we also have auricular cartilage, that's the cartilage in your ear. And forgot to say that these different kinds of cartilage, although they have those collagen 2 and aggrecan, what makes them different is they have different ratios of other extracellular matrix proteins. So the articular cartilage, it makes a specific kind of protein called lubricin, and based on its name, you can probably guess that it covers the surface and it sort of lubricates the joints. So, in the ear, for example, we have a very elastic kind of cartilage, and it has lots of this protein called elastin, which again kind of describes what it does. And of course, we have cartilage in our nose and in our trachea, and also the meniscus, which again is also in your joints, and particularly in the knee. You can see it's this cartilage here. That's kind of stabilizes the knee joint. And we also have that growth plate cartilage that I talked about before. And growth plate cartilage expresses a particular kind of collagen called collagen type 10. So it's complicated, I know, but I'll try to go through it. So we were wanting to develop methods to make these different, or to reproduce that developmental process and to make cartilage and bone in the lab. And again, this is a simplified view of how we do it, but it has all the essential features. So this is what we would call a monolayer culture, and this is how we grow iPSCs, induced pluripotent stem cells. We grow them in here by adding different growth factors. In 4 days, we can turn them into some progenitor cells, and then we put them into a pellet culture. So this is a three-dimensional culture system where all the cells are together in a little ball. And we leave them in that system for about 2 weeks, and then we put them into dishes where, and then we put them on a platform that rotates. So these here, the balls are sort of constantly moving around, and we end up with these cartilage balls here that you can see. So we have these little balls of cartilage, and if any of you are meat eaters, you might recognize that this looks very much like the cartilage you see on the end of your sort of lamb roast joint. It's smooth, it's shiny, it's kind of crunchy. It's really very much like what you would see in animals. And we can also, by changing the sort of conditions that we grow them in under and the growth factors that we add, we can make different kinds of cartilage. So we can make this articular cartilage, we can make the growth plate cartilage, we can get them to mature to become hypertrophic, and we can get them to transition to become osteoblasts or bone cells. And so this is really just showing you how the different cell types, the different kinds of, how we can make these different kinds of cartilage. And what you'll see in the images that are coming up, we've actually done some histology to look at what the cartilage looks like. And these are images taken under microscopes, staining for the various cartilage components. So this is aggrecan, this is collagen 2. In articular cartilage, we see this is lubricin, which is articular cartilage specific. And they're not expressing collagen 10, which is good because we don't want them to do that. They shouldn't. We can make growth plate cartilage, and our growth plate cartilage doesn't express lubricin, which again is good. It shouldn't. And at this stage, it's not yet expressing collagen type 10. But these cells can mature and they can become hypertrophic and they can express collagen type 10, which is great. And then we can induce these cells to transition to become osteoblasts, and they're the main cells in bone. And osteoblasts express a different kind of collagen again, collagen type 1. This is another osteoblast-specific protein. And this is micro-CT, so this is like an X-ray, three-dimensional X-ray. And what it's showing is that the bone is mineralized, and the tissue that we make is able to mineralize and form a bone-like tissue. So I guess what's unique and pretty special about our method is that we now have cartilage cells or chondrocytes in a developmentally appropriate three-dimensional cartilage extracellular matrix that the cells have made themselves. And so it's just like a human tissue that you would get inside a body. And these images are really just to really emphasize the three-dimensional nature of it. And you can see these little holes here. These are the holes that the chondrocytes would sit in. So that's the technology. So as I said earlier, we're using this. So most of the work in my lab, we're using this system to model genetic disorders. But when we saw, and I'm not going to talk about how any of that data today, but when we saw how beautiful that cartilage was, we thought to ourselves that it might be ideal as a biomaterial for repairing cartilage or bone defects. And of course, there's a huge and unmet clinical need in this area. And I know you are very aware of the unmet clinical need for osteoarthritis. And so osteoarthritis is a degenerative disease where you really lose the cartilage on the ends of your long bones. And it's often just an age-related thing, because cartilage is very, very poor, has a very poor ability to repair. So if you have any kind of injury, you'll get arthritis a little earlier. And so you end up losing the cartilage, you have bone on bone, pain, inflammation, and there's no cure. So it's really just management, it's managing pain, and eventually joint replacement. But there are other potential uses for our material, and one of them is osteochondral defects. So this is a defect that affects the bone, the osteo, and the cartilage at the same time. And often this is post-injury, and you'll see this in people of any age. And another really big clinical need is in non-union fractures. So these are ones where the bone's broken, the gap between the two pieces of bone is too large to repair on its own. And again, this will be post a fairly major traumatic injury, can happen at any age. So if we could help to repair that would be a fantastic outcome. And bone repair is also really important in various other systems like cancers, bone cancers. So if some of your bone has to be removed because you have cancer, then it's very difficult to repair it. So in head and neck cancer, often the radiation therapy destroys the cells in the bone of the jaw and other facial bones. And there's, again, no good way to replace that bone at the moment. And of course, there are potential dental applications as well. So the model that we decided to test our cartilage in first was what we call was an osteochondral defect, which is a cartilage and bone defect in the trochlear groove in the rat. Now, the trochlear groove is in the femur, which is the main long bone in your thigh, and it's at the knee end of it. And it's the groove that your kneecap sits in. So it's the thing that keeps your kneecap, or helps to keep your kneecap in place. And in the rat, it's much more weight-bearing than what it is in humans. So what we did was we made a defect in this region in the rat. And it was 1.5 millimeters in diameter and 1.5 millimeters deep. And so the idea was that we would make our iPSC-derived cartilage, and we would implant that into the defect and then see what happened. So this was the kind of experiment, this was the design of the trial. So we decided that what we would do is differentiate our stem cells into, sorry for the change in terminology, but from now on, the surface cartilage is what I've been talking about as articular cartilage. Deep zone cartilage is the growth plate cartilage. So we would differentiate into these two different kinds of cartilage. And then we would compare an unoperated limb with a defect where we didn't put anything in, a defect that we put the articular cartilage in, one that we put the growth plate cartilage in, and this is a cartilage that can turn into bone. And this then one where we thought we'd be really clever and put in a laminate that had the growth plate at the bottom and the articular at the top. And then we compared, we had 3 different groups of rats. I'm only going to talk about the group of rats that had implants for 26 weeks, so around 6 months. At the end of the experiment, we did micro CT of the joint, which is that 3-dimensional X-ray. And we did histology, and we looked for the expression of various cartilage extracellular matrix proteins. We also did assess pain in the 6-month group. I'm not going to talk about that tonight because there wasn't any, we didn't find any difference in pain in the different groups. So the first thing we had to do was work out, stage of differentiation we should choose to put for our implants. So, the protocol goes for quite a long time, as you can see. Up here we're talking about 53 days, so it's quite a long time. And we wanted to know which time point was best for implanting. And so to assess that, we did histology of our cartilage. So again, this is our articular cartilage. This is our growth plate cartilage, staining for collagen 2 and aggrecan, which are in all the cartilage types, which is great at all the time points. This is lubricin, which we see at all the time points in just the articular cartilage, and collagen 10 down here, which is never in articular cartilage, but we eventually see it being expressed in the growth plate cartilage. And then the time that we decided that we'd implant at around cartilage that was around this time point. And that was because we know that it has the potential to turn into hypertrophic cartilage and then go on to form bone, but it's not there yet. And so it might be able to respond to different signals coming from the rat. So we did a lot of tests on the cartilage to, really define in a lot of detail the cartilage types. And again, they're clearly different in the kinds of proteins that they express and all that. But one of the other things that we did was we looked at the mechanical properties of the cartilage, and without going into the complex details about how we did that, what this shows is that the articular cartilage is much stronger. So it's able to withstand a lot more pressure before it deforms. So it's a much more robust kind of cartilage. And the growth plate cartilage, which is a cartilage that's designed to be broken down and replaced, is less robust, and that sort of fits entirely with what we would expect. Okay, so the first thing we did with the rats that had been implanted with these various cartilage types was we did the micro CT. So again, it's a three-dimensional thing, but the images that you can see is just a slice through that three-dimensional image at around the center point of where the implant was. Now, there was a slight, as often happens with research, there was a slight glitch in our experimental design, and that was that actually the defect where we didn't put anything in, where we had no implant, actually healed quite well. So in these micro CTs, let me orientate you. So this is where the articular surface would be. So this is the trochlear groove, and remember that cartilage doesn't come up on X-ray because it doesn't have any mineral. So cartilage doesn't come up. So what you're seeing is bone. And all these bits that are out here, that's the kneecap. So you can see this is an unoperated joint. You can see lots of bone. This is the defect alone, and it repaired. And we're like, it shouldn't have done that. Because according to the literature, the critical size defect, which is a defect that won't repair on its own, is 1.4 millimeters in diameter and 1 millimeter deep. And ours were 1.5 diameter and 1.5 deep. So they shouldn't have repaired. They did. We don't really know, but we think it might be because the way that the surgeon made the defects was really gentle, and he didn't damage any of the tissue on the sides. And so maybe that's why it was able to repair. We don't know. It's a glitch. Nonetheless, we can tell quite a lot from our experiments, from the data that we did get from the implants. So when we put in the articular cartilage, you can see here that there's no bone coming up on the micro CT. So it's not turning into bone. When we put in the growth plate cartilage, the bone is repairing really nicely. And when we put in the mixture, so it had growth plate in the bottom, articular on the top, again, we don't see any repair. So here's some histology of what the bone, what it actually looks like. And what you can see on the top row is histology stain for cartilage, which is shown here in purple, and bone, which is here in the pale blue, and all these sort of white with darker blue dots, that's bone marrow. So this is the defect alone that shouldn't have repaired, and it did. So when we put in articular cartilage, you can see that after 6 months, the cartilage is still there. It's still very strongly staining for the cartilage marker, the cartilage proteoglycan. This is the growth plate cartilage, and again, it really emphasizes that we have bone there. And this is the hybrid. Again, it's still staying there. In the next row of images, we're staining for collagen type 2, which is the cartilage specific, or all cartilages, and you can see here it is on the articular cartilage. And in the surface, when we put in the articular cartilage, you still see it. You see the collagen 2 here. So it's staining with both of those cartilage markers. And the green that you can see up there is collagen type 10. And so that suggests that actually these down here, the cells are kind of changing from articular cartilage to growth plate. And maybe eventually they would turn into bone, but certainly in 6 months, they're not doing that. We're getting really lovely bone repair in with the growth plate cartilage, and the composite is still there. PRG4, this is lubricant. Again, it should be on the surface of the cartilage, which it is in all the groups. That's great. And this is collagen type 1. This is the bone-specific protein. And again, you can see lovely bone repair when we use the growth plate cartilage, and no bone at all when we don't. So what that tells us is that our articular cartilage is resistant to breakdown. And this is actually good news, because it means it's going to be great for repairing articular cartilage. And it's likely to be very robust and to stay there. Whereas our deep zone cartilage, so our growth plate cartilage, it promotes bone repair. And so it's probably an ideal material for non-union fractures and other bone repair situations. So we're really excited about this data, and we're really hoping that now we can do some more experiments to show, to show in more detail the utility of it. So I think, arthritis is a major thing that we'd really like to concentrate on. The problem with the rat model is that the rat articular cartilage is only 200 microns thick. So that's like 1/5 of a millimeter. It's very thin cartilage, and it's just too thin to really be able to do repair. It's too hard to do the surgeries, etc. So we've been talking to someone who would like to try our cartilage in a goat model, and the goat is probably the animal with, has quite thick articular cartilage, so it's much more amenable to cartilage repair strategies. So we would like to do that, and we're looking into ways to get funding to do that. And the other one that we would really like to do is the non-union fracture repair. And there is actually a model in the rat, which makes it very easy for us to go ahead and try to repair the bone. So I think that's it. That's where we are with the repair, the cartilage repair. And I just really wanted to thank all the current and past members of my team at MCRI, and various collaborators, and of course the funding bodies. So thank you.
So thank you very much for setting the scene. And now it's my turn. So I'm going to share my slides. So I'm Megan Munsie. So I work also at MCRI, as Shireen had just mentioned. And I hope you can see my slides now. Yes? Yes, excellent.
Yes, so we're seeing presenter view.
Oh, excellent. Okay, I'm going to swap views. Does that make a difference?
Yes, perfect.
Excellent. All right, so I would really like to talk to you about something slightly different, a bit adjacent. And my research, even though I'm a stem cell scientist by training, I'm really interested in kind of the implications and I suppose the rules and regulations around stem cell science. And I'm particularly interested in what I think is a gap between what we do in the lab and what people think perhaps we're capable of doing. and how and when stem cells should be accessible. So I want to kind of talk about this kind of intersection between what we expect and what we can do. And I want to really share some of my more recent work. But I want to start with sort of talking about how people find out information about stem cells. It's fantastic you're all here tonight to hear us talk about our work directly. But unfortunately, so many people find out about stem cells through headlines like these. And maybe you even saw some of these headlines, or you followed with great interest Rafael Nadal's attempts to improve his shoulder and back with stem cells, or maybe Adam Gould's. Or perhaps you've heard about stem cell treatments for arthritis in dogs on this ABC story, or more recently on other channels. So where are we at with stem cell science? And maybe you've also done some Googling and found a clinic like this one that I found today. This is a clinic that seems to be selling treatments that seem to be proven, and they seem to be selling them in Australia. And if you look on the website, they are claiming to have a stem cell treatment for all of these different conditions. So cartilage defects, rheumatoid arthritis, hip, knee, shoulder arthritis. If you dig a little bit deeper on the website, they also claim that the same treatment can be used for obstructive pulmonary disease, heart failure, diabetes, headaches, migraines, autism, post-stroke, and many other conditions. Now, that raises some flags for me, and I'm going to come back to that point in a minute. But many people are also getting their information on social media channels and on YouTube. And this is particularly compelling because often they're videos and interviews with people like us, people who have the same condition, who have pursued these treatments. And this is just an example of one I found today, and I thought it was fitting with the Winter Olympics on. And it's pretty compelling when you hear from someone who's gone through a treatment that it might help you. So unfortunately, what we're finding, and I hope some of you have seen this page on Musculoskeletal Health Australia's website. It's something that we prepared many years ago now through collaboration with us and also the Royal Australian College of Sports Physicians, trying to kind of bridge this gap between what we can and what we can't do, and really challenge some of what I think is blatant misinformation and, quite frankly, unethical practice by clinics like I mentioned a moment ago. So I've been watching this space with great interest and concern for many years. And this image on the right is a heat map that's kind of showing the number of clinics that are selling unregulated, unproven treatments. So as you can see on the left-hand side, these treatments can start at, say, $30,000 US, but some of the clinics even sell them for $100,000. And if it hasn't worked the first time, they encourage you to come back and try again. Now, I want to make it really clear that one of the reasons why I think these practices are unethical is they're yet to be tested. They're yet to be proven. And as you might have noticed in this heat map, this was published back in 2016, but you can see that the darker the color, the largest number of clinics are operating in the USA, not in sort of far-flung locations where you might think that there's sort of less regulation and less oversight, but it's happening in America, and it's been happening in Australia. And in Australia, I've been following this and tracking it for many years. And initially I saw this growth. More recently, I published a paper that showed we got up to about 50 clinics operating in Australia. And one of their key markets was pain and arthritis. So this was using the patient's own cells, and there was a loophole in our laws that allowed that. We've now closed this loophole, which I hope will encourage more regulated, thorough investigations. So what do I mean by that? The reality is that whilst stem cell science has lots of promise, we haven't got many proven treatments yet. And by proven, I mean that they're safe and effective and have been demonstrated to be such to the standard demanded by our regulators like FDA and TGA. as you remember, during COVID, they were responsible for regulating and overseeing vaccines and vaccine development to counter the pandemic. And they have a similar role when it comes to cellular therapies. So we want to make sure that we do studies, and Shireen's giving you some beautiful examples today of the work, the careful work she and her colleagues have been doing around this kind of far left-hand side of the spectrum, which is making sure first in preclinical and animal models in the lab and in animal models that we're seeing that these cells should work and they should be safe. But quite frankly, it's not till we do clinical trials, clinical research, or we start putting the cells back into people that we really will be able to answer, are they safe and do they work? And when we think about clinical trial design, it goes across these phases, where the first phases are usually on a handful of people to test purely safety. Once we know that the intervention is safe, we'll then start trying the intervention on larger groups of people, but also with a control. So we know that some people have had the intervention and some people have not. And the people who are assessing, the medical doctors who are assessing whether there's been benefit or not, will often be what we call blinded. So they won't know what the patients have had, what the people in the clinical trial have had, whether they've had a placebo and they're in the control group, or whether they had the intervention that we're testing. And that is a really good system to make sure we're not biased, because of course we're all hopeful it's going to work, and that can cloud our judgment. So we take that evidence to the regulator. They often oversee this process as well, but we present the evidence to the regulator, usually after a phase 3 study, which involves this blinded controlled study, and we get them to assess it. And that's what I mean by proven. Unfortunately, many of those interventions I shared with you earlier are outside this clinical trial. They're claiming they can already treat people without having gone through this rigorous and careful process. And I think this is important. When we think about the example I gave before, where they're using the patient's own cells, maybe obtained from fat, and injecting that into the joint, or even perhaps taking cells from cord blood and injecting that into the joint, it matters how those cells have been prepared and by whom. And so have they been prepared in a laboratory with appropriate standards and controls that will prevent infection and transmission of infection? Just because it comes from you doesn't automatically make it safe. Because it comes from a donor, there may be chances of infection from the donor. It also matters how the cells are manipulated in the lab. We could inadvertently make an error in the cells that could make them grow into something we do not want in the knee, for example. So it matters. So just as Shireen has explained to you, what we demand in science is this careful, rigorous, ethically responsible translation. And when it comes to evidence, we're still collecting it. There has been a study recently published by Sam Whittle, who's a rheumatologist in South Australia. And this is called a Cochrane review, where he looked at clinical trial data, he and his team, across 25 studies, 25 clinical trials using stem cells for arthritis. And as you can see in the article that he wrote and published last year in April in The Conversation, and if you'd like to access that, you can very easily. As you can see from the headline of this article, Sam and his colleagues are really concerned that people are being subjected and are accessing these unproven, costly interventions that we don't even know work. So in this study, they've shown that there may be promise, but the evidence just isn't there yet. And they make a case in saying we must continue to gather the evidence in clinical trials, as I just discussed, and be very wary of rushing to the finishing line, if you like. I just wanted to counter that work with perhaps some public opinion data. So this was a paper published back in 2011, and it involved almost 1,000 Americans who completed a survey. And what I think is really interesting, particularly when you remember what I said earlier when I showed you the heat map, that there's a lot of clinics in America that are advertising directly to people through websites, through all sorts of things, even ads on the radio. And as you can see, a lot of people who were participating in this survey thought that there was already sufficient evidence that stem cells can be used in orthopedics. They already thought, or many of them, or more than half, thought the FDA, the regulator in the US, had approved it. Almost 3/4 thought it could stop pain or alleviate symptoms, and about half thought it would even cure arthritis. Now, this simply isn't backed up by science yet. Again, we're all hopeful that this will be true, but we're still a little bit cautious about whether it's an intervention that will work, and what we need is research. So changing tack a little, I just wanted to finish by telling you about a study that we've been doing in partnership with Musculoskeletal Health Australia and other charities and groups around Australia. And this was funded by the Australian government and the Department of Health a couple of years ago. And we being a group of bioethicists and social scientists, were wanting to understand more about how do Australians see this. I've just showed you some American data, but what do Australians think about stem cells? And we explicitly talked to people, a couple of dozen people who live with arthritis or other musculoskeletal conditions and in other disease categories. And I just want to quickly show you a teaser from our unpublished results. And I wonder whether this resonates with you. So one of the strong themes that came out when we spoke to people with lived experience in musculoskeletal conditions, particularly arthritis, said that they were uncertain about stem cells. They didn't really know much about it. They didn't know if they worked. They didn't know about the risks and benefits, and they didn't know how to access them. So perhaps they didn't really understand this delineation between clinical trial and what's being offered in the kind of more unregulated space. And you can see a quote here that I've just grabbed from our unpublished data, where the person who shared their insights with us was saying that they really don't know, that they're not sure about the risks, and they've been doing a lot of reading about it before they consider it, which, obviously is a reasonable stance. They also were very aware that they didn't feel like there was any trustworthy science-based information available. So they perhaps hadn't seen our excellent resources on the website. But they were wanting something that's accessible. They want some information to help them make an informed choice, to help them navigate perhaps the information they're encountering or that family and friends are presenting to them. And the other interesting finding I wanted to share was that, and again, I think this is probably of no surprise to you, that people were seeking treatments that reduce pain and helped with management. And this is a quote from someone who says, who was reflecting on their condition and that it was unpredictable how they'd feel every day. And the main thing, of course, was managing the pain. And they did this through different modalities such as physiotherapy and hydrotherapy and massage. So, of course, if stem cells could alleviate pain, that would be extremely attractive. So what's on the horizon? I've said that we must do more clinical research. Well, I wanted to share with you, and perhaps you already know about this trial. There has been a clinical trial. It's now closed, and we're waiting with great interest the evaluation of the outcomes. But this was one of those larger studies that had a control arm, so people who've had stem cell treatments and people who hadn't. And as you can see, this trial started way back in 2020. As I said, they're now closed and are carefully evaluating information. This probably won't be definitive. It may not provide all the answers, may not provide sufficient evidence, but it's a really good step in the right direction, I think. And I just wanted to clarify that the cell source that was injected into people who participated in this trial was actually slightly different to what I mentioned earlier. It's a very defined product that's actually made by a company from a donor where they make stem cells and then they make a particular type of cell called an MSC, or a mesenchymal stromal cell, that's thought to have an immunosuppressive property and possibly even a regenerative property. But that's being assessed. But the product is quite different. It's from a donor, it's not from you, but it's highly purified and highly categorized and characterized, I should say. So that's one example of what's happening. Another study that's just taking off, as you can see here, I've done a screen grab from the Clinical Trials Registry in America. This is a study that's funded by the Australian government through a granting scheme, and it involves Charles Sturt University and a Melbourne-based biotechnology company. And they haven't started recruiting yet, but they will soon. And their product also has been made from a donor, and again is really well characterized. But there's a slightly different method that they've used to make the same population of cells that are being evaluated in the trial, the Sculptor trial I just mentioned. So I just wanted to illustrate that there's things happening in Australia, and so we are contributing to what a great deal of work that's happening around the globe. And I really encourage you to keep watching this space and following this research, because I think we may not get all the answers in these first large clinical trials, but the evidence is being evaluated, and that's what we need to see. We need to work together to collect a solid evidence base and find things that work. We don't want to see people wasting their time and money on things that don't work. So again, I just also like to acknowledge my collaborators. Apologies for using the old logo, the MSK, but I'm very fortunate to work with some absolutely fantastic people at MCRI and elsewhere around Australia and internationally. And I'm going to say thank you there and stop sharing. And if we've got any time, I'd be delighted to take any questions.
Thank you so much, Megan and Shireen. That was excellent. We will forgive you for the logo. That's all good.
Thank you. You're very generous.
Oh, no problem. But just want to say to everyone that obviously there's quite a lot of information, both from the technical perspective and then from the ethical, social, regulatory considerations to take in. So we have recorded this so that you can certainly go back and rewatch it. I'm not a clinician, so I certainly will be going back and rewatching parts of it just to get a better understanding and grasp of what's going on. But again, thank you both so much for presenting on this topic tonight. It's definitely at the top of people's minds. As you know, in our community, people are struggling with pain, isolation, and looking for solutions. And I guess just before we wrap up, probably maybe the $1 million question you might call it is, I guess, if you're living with chronic pain, you don't want to go through a joint replacement, so you're looking to these kinds of therapies, when do you think that it might actually become a recognised treatment that would be available for people? Keeping in mind, we can see that it's going to be a while, but
that's a fantastic question and a really tough one, because it's really hard to predict. And I think it's an excellent question, because of many of all the conditions that I kind of follow, this decision making, whether I should have a replacement or wait, is really tricky. Or even to take something that's experimental. And I suppose the first thing I would say is I probably won't give you an exact year, but I think it will be some time. I'm hoping that these new larger trials gives us some data that's really strong. That would be ideal. But it might be a little bit weak. It might send us back to the drawing board. Often when we talk about clinical translation, like that image I showed you of preclinical to different phases to proven treatment, it always looks like it's like a stepping stone. But often what it means is we have to go back. So we find out something which is useful, but we have to go back to the drawing board and start again, which is, of course, no help to people in the community who are living with pain. But I think it's a reality check. So I think at some point, if your pain is really severe and there's not yet a proven treatment or an opportunity to participate in a clinical trial, I would, perhaps go with a proven intervention rather than risk my health and my money on something that someone might say is proven, but my specialist tells me it's not.
That's a good answer, and appreciate your transparency. Also, because I think it would be great to say it would be in 20 years' time, but as you clearly pointed out, there's a lot of considerations to take into account with what's happening in research. And I guess maybe one other question, because I'm just conscious of time. We, as you nicely mentioned, we've got a little bit of information on our website, and there's also the study that's happening in the background that we've been partnering with you that we're looking forward to seeing the results of. But I guess obviously there are clinics, operating within Australia and globally. So if people sort of want to explore that path a little bit more to inform their decisions around their healthcare, where is a good place, or what are the sorts of things that might identify that somebody is, or a practice is actually doing what's required to stay within the ethical and research boundaries of treatments or
So
potential options?
So again, great question. And we've developed a checklist over the years that I can share with you
Yeah,
and
that would
send
be
you
great.
of questions you can ask. So I think it's great to do your research. And I think perhaps until you do your research, you can't leave it alone because it's sort of like you can't leave any stone unturned.
Yeah,
So I do think people should do it. I think they should speak to these people who claim to be offering something. But if it sounds too good to be true, keep doing your research and take it back to your specialist. Take it back to someone who knows your condition, who's not likely to profit from this. Because I think that to me is the most concerning element. I don't doubt that the people who are offering these treatments are enthusiastic and are there wanting to help people. I don't doubt that at all. But they're also operating in a really grey ethical zone because they are charging you for something that they shouldn't be, in my opinion.
yeah,
And I know a lot of, conventional medicine, we could have an argument about the level of evidence, but I still think we should be asking for evidence and not just letting people put up a shingle, a sign or a website and say they're doing it and not have the kind of appropriate recognition and credentials. A lot of the doctors who are doing this kind of treatment are cosmetic surgeons. They're not surgeons by kind of classical definition. They're people who have access to a liposuction machine and are enthusiastic about using the aspirate from the liposuction machine. And there's other examples I could go on, but I think, I really think we have to I would be encouraging people to find a specialist that they trust. And even if it's not the first one you have a conversation with, because from our research, we well understand the merry-go-round and the
yeah,
diagnostic odyssey, and the first rheumatologist or specialist you meet may not be the right one for you. But keep looking because you will find someone, but perhaps not someone who's selling you stuff that isn't proven.
yeah. Okay, that's great. Thank you. Um, Look, unfortunately, we're just out of time, so we will have to wrap it up there. But again, thank you so much, both of you. We'll definitely get in contact to get that list of questions, because I think that will be very helpful for people to just empower their healthcare discovery journey, and just getting the information they need to make good decisions and beneficial decisions. And as I said to everyone, there will definitely be a recording so that you can rewatch this as many times as you need to. But of course, if you're looking for more information, please visit our website or give our helpline service a call. That number is free as well. But yeah, thank you so much, Megan. Thank you so much, Shireen, for your expertise, your time, and generosity in being here with us. And yeah, wish you all a very good evening, and we will see you at the next webinar. Thank you so much.
Thank you.